Bye. And realize.
Happy Wednesday night, everyone. Welcome to the Crowfoot Village Family Practice webinar. My name is Rick Ward. I'm one of the senior family physician partners here at Crowfoot Village Family Practice. It does not mean that I'm senior in terms of power, but I'm senior in terms of age. So I'm the old guy on the block, and it's going to be my pleasure to lead you on a cool journey tonight to talk about where Crowfoot is now and where it's going in the future. And really, that's what the objective of tonight is. You know, the Crowfoot Village Family Practice of today was really the brainchild of Dr. Peggy Offrick. And believe it or not, this is 25 years that we've operated under this unique funding model. I know there's some of you that are online that say, well, I remember when you were over in the strip mall at the vet clinic, and remember hearing the dogs bark. So there's been a big evolution, but the big evolution has started with Peggy's vision 25 years ago. So this is a bit of a state of the union about where we are after 25 years, but more importantly, it's a vision of where we're going. And I think that's the really exciting part of this. Before we jump into things and bring on our panel, I would just like to acknowledge that respectfully, we're here and gathered in Treaty 7, where it's an honor for us to provide care. This is a traditional gathering place for diverse Indigenous peoples, including the Blackfoot Confederacy, the Tsuut'ina Nation, Stoney Nakoda Nations, and the Métis Nation of Alberta, Districts 5 and 6, whose cultures, histories, languages continue to influence the community. As we know, the First Nations medical issues and social issues are a burden for all of us and a challenge for all of us to work on. So just wanted to start by acknowledging that. So just some guidelines with the chat. And hey, I see some of my peeps are on there and chatting. We love the interaction. Just a couple of guidelines. Yes, they're new glasses. You know, don't need to let me know today what you think of them. True, my wife did pick out this shirt. For those of you who are my patients, they know that. The cool shirts were her decision. Please, this isn't a forum for your medical issues. So, you know, if those hemorrhoids are an issue, then maybe make an appointment and don't share with the chat. We'll try to address the questions that come up that are there. So feel free to interact with us, but know that some things we'll be able to respond to. Yeah, I want to start with a story that maybe gives a little bit of a perspective on tonight. Last week, a couple of my dear long-standing patients came in to see me, and at the end of the visit, they said, "Rick, we've got a neighbor who's an older person who's just received a really terrible diagnosis of an aggressive cancer, and he doesn't have a family physician, and I wonder if you could take him on." And we hear those kinds of stories every day as physicians, as well as our nurses and other team members. And there's a moral distress that it leaves us with, because in my heart, I'm saying I would love to look after that patient. But I also hear every day, you guys are so busy, it's so hard to get an appointment. And if we keep bringing those patients on, then we're not going to provide the kind of care. I'm going to come back to that at the end of this webcast, because we think that we're going to be able to help find a solution to some of these issues. So the hook on this is stay tuned, because this does have an ending. Hey, let me stop doing all the talking and maybe tap on some of my colleagues to give some perspectives on things. I'd like to first ask Yan you to come online. Yan is one of our bright young leaders. He's been in practice, I think he's over the 5 year mark. He's got a huge interest in mental health, particularly childhood mental health, and he's started a great initiative outside of this clinic that's addressing that big gap. He is also a leader. He's on the board of directors for the College of Family Physicians of Canada, so he has a real national perspective. Yan, just maybe if you could start by sharing with us what the state of primary care is in Canada and medical home, and maybe a little bit about where CVFP fits into that.
Thanks, Rick. Is everybody hearing me okay? Yeah, great. So in terms of family medicine in Canada, there was just recently a Commonwealth report released that has Canada ranked last in terms of access to be able to see a primary care provider. Some of you are probably feeling it and experiencing it yourselves. And alongside that, we know that patients' needs are evolving too. So healthcare issues are becoming more complicated. Patients are having multiple issues that need to be addressed. And as a response to that, family doctors have tried to sort of reorganize themselves into more doing things in terms of team-based care. So having a team of primary care providers looking after all the healthcare needs that we see our patients are suffering from. There's been some research that's done on this. So team-based care, like what we have in Crowfoot, has been shown to improve access. It's been shown to improve patient satisfaction, and it's also helping to prevent medical issues from happening, and to prevent people from needing to visit the emergency rooms or stay in hospitals. So where do we live fit into the primary care landscape? Well, I think we're the model clinic for the patient medical home concept, that team-based care concept. For my work on the College of Physicians of Canada, we like our clinic, CVFP, is on the National College's website as a model clinic. And at least that's one of the reasons why I joined this practice five years ago after I graduated residency, was because I think we are the future of primary care and how family medicine should be done.
Yeah, thanks, Jan. And it's great to see somebody who is new in practice that's excited by Crowfoot and coming in. Do you see more of the Crowfoot model happening across the country, or are we a bit of an island?
Fortunately, we're no longer as much of an island as we used to be. In provinces like Manitoba and BC, they've recently revamped their physician payment systems to better incentivize these sorts of longitudinal team-based care models. It's also been going on in Ontario for many years, but again, funding limits the ability of family physicians to organize in that format for their patients. But right now, at least I know that there's both provincial and national advocacy in this front to try to bring about more team-based care.
Yeah, and I want to pick up on one of your points, and I know that it's a point that'll be reiterated later on tonight. It's really a funding model that's allowed us to innovate and has sort of taken the handcuffs off. And I think what I hear you saying is that as other provinces and other areas are unshackled from an old funding model, it allows them to innovate as well.
Exactly. Yeah. So it does require a lot of different stakeholders, from patients to governments, working hand in hand with us to sort of help us expand this model to other family doctors across the province.
Yeah, sort of a necessary but not adequate. I know that long-term CVFPers will talk about the change management that was involved. But listen, that gives us a really excellent sort of sense and a lay of the land. We were told that we're not supposed to use the C word, crisis in family medicine, so we're in a no crisis zone, positive looking towards the future, but you've given us a good sense of the landscape nationally. Let's zoom down to Crowfoot Village Family Practice and bring on Dr. Wendy Stefanik. Wendy is the chair of our Physician Corporation Board and at the helm of really the kind of changes and vision that we're going to make. Wendy, the Crowfoot Village Family physician owners sat down and had a retreat earlier this year and set a bit of a direction for the future. Can you share a little bit more about what the board committed to?
Yes, thanks, Dr. Ward. As Dr. Ward mentioned, am the chair of the board, and the board really, for those who don't know, consists of the owners of the clinic, as well as two faces you see here tonight, Shauna Tomey, our executive director, and Dr. Janet Reynolds, one of our physicians and our medical director. And so when we met together this year, we really decided that we were going to tackle some big issues that are facing primary care. We're feeling them at Crowfoot. Everybody's feeling them to Jan's point across the country. And we really felt like we were also really uniquely positioned to offer some solutions to these challenges because we've really been practicing team-based family healthcare for over 2 decades. One of the solutions we really wanted to address was the lack of attachment of a lot of Albertans and really Calgarians to a primary care provider. We also wanted to focus our attention on how to improve access for all of our patients. That includes our current panel of patients as well as our unattached and hopefully sooner to be attached patients than later. Now, that's easy to say. It's a nice goal on paper. It's a great mission. The hard work is in how we deliver on those problems that we want to solve. And so really we've committed to working together as a team. We've got a smaller working group that is focusing on some more internal efficiencies to try to optimize our current team. Some examples of how we're doing that for you guys would be, you might notice improved access, or we're hoping you're going to notice improved access to different team members. That may not necessarily be your physician, recognizing that we are becoming a more scarce resource and we don't have special access to hiring more physicians, not unlike anybody else across Alberta. So we really decided we had to be quite creative at how to improve our access, recognizing that there are fewer doctors really to go around than there ever has been. So you might notice that looks a little bit different if you call into the clinic or you have information relayed to you over the phone or by email. You may be in touch with somebody else on the team that we feel is actually really, in many ways, better positioned to help you with those needs than your physician might be. The other efficiencies that we're working on include just improved communication with the clinic, whether that's email or hopefully in the future, some improved electronic, more enhanced electronic communication, and just really making sure our electronic medical record works to really its full scope. Like we want our people to work to their full scope. We want our electronic medical record, your record, to work to its full capacity. So hopefully stay tuned for some changes. Some might be minor. You may not notice them. Hopefully some bigger changes coming down the road that will hopefully enhance and improve your access to care and your care experience at Crowfoot. Most importantly, we really felt like we could offer what we do best to patients who do not have family or primary care in our community. And we know most of our patients come to us often with requests or asks to take on their family members, take on their friends. Really, often it's a no, I'm sorry, I'm full, I can't, my wait times for you to see me are already long enough. In order to be able to expand that access to our clinic, we again, we need to enhance our team, and we're hoping that in what I just spoke to, we can start to say yes more, and also look at our waiting list, which is quite large, if you haven't noticed.
Yeah, actually, Wendy, let me follow up on that. Remind me, how many patients are we providing care to right now?
24,000-ish, between 24 and 25,000.
All right, we'll get the latest figures from Shauna. And roughly how many people are have been on our wait list?
We are, I think at max, we were around 4,000. We have been able to, which I think will be spoken to later on in our presentation, been able to bring some patients in off of that wait list. And still probably we're looking at 3,000 and some. So not a short wait list.
Right.
Not as long as waiting for Taylor Swift tickets, but
but way better once you get in, as long as you don't ask us to sing. Listen, is there a specific? So I'm hearing a couple of things that we should look for more efficiencies in how we're delivering care within Crowfoot. That will include maximizing team members. I know that we may have a 2.0 of our email communication with patients. And I also hear that we're going to take on some new unattached patients. Is there a goal for that? Is there a number, or is it an aspiration that without definition?
There's a bit of definition. We felt like we needed to come up with a concrete target, or we would maybe not have the goalposts we need to work towards. So we did set a target of 15%, approximately, I think 3,500 patients, Shauna. If we beat it, excellent. If we don't make it, or it takes longer, because of course we want to do this well, then that is what it is as well. So that's our rough draft, I'll say.
Great. So one of the headlines from tonight is that Crowfoot is going to start taking new unattached patients. And again, stay tuned for the how and how we're going to do that. Thanks, Wendy. I'm going to pivot over to Shauna Tomey, who's our executive director and really our inspirational leader in the operational team. Shauna, as well as being a medical home and providing outstanding service and healthcare to patients, Crowfoot is also a business, and that's in your ballpark. So, what's the health of Crowfoot Village Family Practice as a small business right now?
Yeah, well, I think I'm going to reiterate a few things that Jan and Wendy both said, as well as sort of where you started, Rick, which was our funding model is 25 years old. And I really want to talk about that and what that means for Crowfoot, as well as what's happening in the landscape of primary care. So for the benefit of those of you joining who haven't been with Crowfoot since the dogs were barking in the vet clinic next door, maybe I'll just kind of do a little bit of a history lesson. In 1996, we collaborated with the provincial government to design a payment model that would support team-based care, which was launched officially in 1999. And we've achieved great success with that funding model. CVFP is one of the most studied primary care clinics in Canada. So in 2019, the Health Quality Council of Alberta did a 10-year evaluation, and what they found was that our team-based approach reduces the number of emergency visits our patients need by about 15% compared to the average Albertan. And if admitted to hospital, our patients' length of stay is 45% shorter. And those two things combined result in an almost $60 million cost savings over a 10-year period. So it's quite significant. And that is the impact of team-based care that Jan was talking about. So if we fast forward, we're really seeing great changes in the last 5 years, and Dr. Yu spoke to that. So I feel like the pandemic definitely amplified this. If we look at 2024, we're seeing patients' needs growing significantly in complexity. We see patients more often throughout the year. So 5 years ago, we were seeing you 3 times per year on average, and now we're seeing you 6 times. And when we see you, we spend more time with you. And that's just because, again, your needs are more complex. We see more mental health, we see more diagnosis of chronic disease, and you're needing more support. And that rings true for all across Alberta. So that's not unique to Crowfoot. In addition, as Wendy said, we have almost 800,000 Albertans without a family doctor. And I want to impress upon you, we will not train enough family physicians to close the gap and to address the evolving complexity of our patients. And so we need to innovate. And CVFP as a business, in order to continue to exist and be a viable, sustainable business, we also need to make sure that we're efficient, which is where we're looking at operational efficiencies, technological efficiencies, and we're looking at bringing in and expanding our team and changing the way that we deliver care. So ultimately, what we're doing and what we're going to share with you tonight is CVFP is designing the primary care of the future. To support the innovations, we need to evolve our funding model too. So the funding model was designed and implemented in 1999 and it's 2024. And so not only do we need to innovate the way that we deliver care, but we need to innovate the way that it's funded as well.
Yeah, thanks, Sean. And I want to unpack some of the things that you said and maybe bring in some of the comments. Larry said, well, you know, look, aren't they graduating more medical students? Isn't this going to solve the problem? And you've heard my mantra that for the last 30 years, I've been hearing we've got to graduate more medical students and they've got to go into family medicine. And still there's a shortage, not just in Alberta, but worldwide. So pumping out more students. But Shauna, and I know Ian, our medical director of education, is on the chat. Have we had any trouble in bringing new docs into the fold as we've had people's practices change?
No, so it's not that. In fact, we continue to expand our team and recruit physicians. So it's not that necessarily that's been difficult for Crowfoot, but I think as well, when we think about the viability, because as you said, Crowfoot is a business, we're looking at bringing in all sorts of providers. And what we've seen over the past 25 years is that it's actually true team-based care that results in improved quality of life for our patients and cost system savings. So we're actually just continuing to expand and evolve the model that we already know exists. And we know that that will sustain us far into the future. And we're looking at being able to spread and scale as much as we can to our colleagues across the province. So really what I want patients to understand or the public to understand is the way that we think about primary care in I have a family physician will need to evolve if we are going to have a healthy healthcare system now and in the future. What you will have is a primary care team. And that could include a family physician, registered nurse, nurse practitioner, physician assistant, or other providers like physiotherapists and mental health specialists. So really what Crowfoot is designing is what that can look like. And we've had the great fortune to do that in partnership with some of our patients.
So Shauna, sort of an evolution from a lightning bolt of a single family physician to the rainbow of a team. And spoiler alert, that's Julie's going to talk more about Team Rainbow and what that means in a few minutes. I think it's my buddy Sandy Johnson who also made the point on chat about, well, isn't your practice getting older? And we absolutely know that the population is, our practice is somewhat, we've still got a fairly average. I think the key thing that we're seeing, not just at Crowfoot, but in the entire system is that the complexity of patient visits is much more increased. And this isn't a Crowfoot phenomena, it is a worldwide phenomena that in the post-COVID world, the intensity and complexity of our patient visits is much more increased. It is rare for me to see a patient that comes in with a single complaint. It's usually 2, 3, or 4, and these are important issues. So we're facing a different time. I think your point about the Crowfoot model of today was designed 25 years ago, and primary care has changed quite a bit in that time.
Exactly.
And how was Wendy for the numbers in terms of?
I can give you the stats. So she was very, very close. So hot off the press, Currently, we have 24,596 patients enrolled in the practice exactly. Our wait list at its peak was 4,300 households. So that's not necessarily individual patients, that's families. So we estimated that that actually might be as high as 10,000 people. So far we've made it through about a quarter of that wait list. So we've still got about 3,000 households on the wait list, and we continue to make it through.
Stay tuned again, another teaser. We have live in front of us, will be in front of you, one of the patients who was on that wait list, who can maybe talk a little bit about what her experience was like being unattached. I'm going to move over and bring on Dr. Janet Reynolds. Janet, CVFP is really full of stars, and one of the brightest is Janet Reynolds. She's been with us for a long time. She has a leadership role in the clinic where she's our medical director that looks after the docs and keeps us paddling our oars in the same direction. And she also has a bigger role in our primary care network where she's the medical director, and she was the co-chair of a very cool initiative called MAPS, which was a sponsored program through the government that was reimagining what primary care is going to look like in the province of the future. So JR, an important document that primary care leadership is talking about every day. Can you maybe share with our patients a little bit about what the MAPS message was and what you see the direction is for primary care in the future?
Thanks, Rick. So not to add to the history lesson, but I've been doing this for about 25 years. And since I've become a family doctor, primary care reform has been on somebody's provincial agenda almost every year. So the need for primary care reform isn't new, but 2.5 years ago, under the direction of the Minister of the Health at the time, Alberta Health started an initiative called MAPS, Modernizing Alberta's Primary Care System. And the mandate was really to look at our primary care system, reorient our entire health system towards primary care. That Commonwealth report that Jan spoke about, we've consistently been falling down how we compare to other Commonwealth countries, and the countries that perform better have a stronger foundation in primary care in their entire health system. So that was the goal of Minister Copping at the time. So reorient the health system towards primary care. Albertans as citizens want to be partners in the care and the development of that health system. So truly meaningful engagement. And I'm so excited that Linda's here tonight as we try to, lead by example at Crowfoot Village Family Practice. Again, enhancing or advancing that concept of team-based care you've already heard about. It's easy to say more team-based care, but our actual infrastructure in primary care has been, loose at best. How the cottage industry of individual family practices are supported with team-based care. And we're actually lucky in Alberta to have had primary care networks for almost 2 decades that provide some extra supports in team-based care. But the outcome of the initiative were 2 reports. And the first one I did want to jump back to, Rick, around your land acknowledgement. So there is an Indigenous panel report, and it is alarming and heartbreaking that there are such health inequities amongst Albertans, depending on your race, and Indigenous peoples have much worse health outcomes. So we really need to do something very different there. And I just wanted to, and so health equity was a really big part of the MAPS panel. And we have some systemic racism in our health system. So provincially, it's really important that we start addressing that. And at Crowfoot Village Family Practice, we actually are urban and don't actually track or understand or know who in our patient population identifies as Indigenous. So our approach is to work on truth and reconciliation where we can, help with some cultural competencies for our staff, and make sure we have a safe space for everyone so that you feel welcome and safe when you come to the clinic. You told me to keep our answers short. So I wanted to jump back to the supportive team-based care. And our model is 25 years old. Most Alberta family doctors are working on a model that's even older than that antiquated fee-for-service model. So one of the huge movements is towards a new funding model option for family physicians, and that will, I hope, leapfrog a lot of the province forward that incentivizes that team-based care you heard Jan and Shauna talk about already. I actually can't emphasize enough that there is no one funding model or business model that will work everywhere in Alberta, in every community, not even in every quadrant of our city. And so we really do want to ensure that we keep options open and consider, the same high principles, expectations of healthcare, Albertans as partners, access when you need it, and not lose sight for simplicity of one funding model, one for all. One size does not fit all. And so drilling back down to Crowfoot Village Family Practice, since 1999, or Peggy Offrich's idea back in the late 90s, we have been leading primary care in Alberta, in Calgary, and even in Canada. And I think the future is bright because now we have strong support for more primary care, Rick. And I think we'll continue to lead. And that's, I think, what the next part of this webinar is gonna show the people that are watching tonight.
Yeah, thanks, Janet, and thanks on behalf of all Albertans for your leadership in this space provincially. So I know you're not the funding person, but there is some noise out there about a new model for primary care funding that incents team-based care, and there's a lot of excellent work being done through the AMA and with Alberta Health on that. So is that going to be a model that you see Crowfoot adopting? Is it going to be a Crowfoot-like funding model?
So I actually don't see Crowfoot adopting this model. I think we want to continue to lead and modernize our current funding model. The purpose of this alternative funding model is to, again, accelerate, 90% of Alberta's family physicians are paid fee for service, which incentivizes volume of patient care for the most part. Of course, the devil's in the details and the reality is much more nuanced. But Rick, this funding model is, details aren't yet public. There's a component to incentivize team-based care. There's a component to talk about what viewers might have heard about that administrative burden, physicians doing work that might not necessarily need to be a doctor to do. But I don't know how it'll apply to us because I don't know the exact details. I think we'll be better off looking at our current funding model, looking at it through a lens of right person, right place, right time, high value care, things that we know improve health outcomes for our patients, and maybe looking at some of the things we need to stop doing that actually don't change a person's health outcomes.
Right, and that sounds like a choosing wisely tagline, another leadership area that JR's in. I think it's timely just to, Alan K. put a question in the chat that said, why the heck aren't there more Crowfoot Village Family Practice like clinics in the province if your model's been so successful? I think that's a rhetorical question for many of us on the leadership side. Jer, I don't know whether you want to give a quick answer to that, but I'm going to use that question to pivot to the future. But why don't you give a stab at that one?
Yeah, I mean, I think partly the answer might be political. There have been barriers. There have been misinterpretations of the original transition. And sometimes political ministries budget in silos. And so when primary healthcare costs a little bit more upfront, and I'd like to remind us all, we spend 50% of our taxes on healthcare. And of the healthcare dollars, probably depending on how you slice health spending, anywhere from 5 to 15% of total healthcare is on primary care. So our foundation gets, not that much of the spending for health dollars, but all of that to say is when budgets are done in silos. If it costs a little bit more upfront, nobody has more money in their pocket in primary care. And the downstream cost aversions or cost savings, again, don't equal necessarily dollars in pockets. They might just be a subtle reduction in a wait time in emerge because our patients go to the emergency department less than other patients.
Yeah, great points, JR. I think I also want to pick up on something that Shauna said earlier and emphasize the efficiencies that we're looking for in healthcare. And I think in broad principles, if there's more money going into the system, there needs to be attention with efficiencies and accountability. Alan, my answer to your question, and we've been asking that question, is we stopped asking it and we started to think, you know what, it's time now to create Crowfoot 2.0, maybe 3.0. It's we can't look in the rearview mirror anymore, and it's really about looking ahead. And that's been really exciting and empowering for the leadership group. It's to see the challenges that we've got, to recognize that there's lots of things that are within our control, and let's use those assets that we have, which includes the leadership who's on this webcast and all the incredible team members we have. Let's talk about the future. So that's sort of where our emphasis is. I promised that we bring in patient voice, and Linda, so glad that you were able to join us tonight. When we started to think about how we are going to deliver more care to Calgarians, the goal that Wendy articulated earlier, set by the board, we took the principle of saying we need patients to help develop that, and so we tapped Linda on the shoulder, and she's been with us in the journey. Linda, welcome, and I wonder if you could maybe just start off by just talking about what it was like to not have a family physician when you signed on to the wait list 3 years ago.
Sure. It was probably about 4 years ago that I found myself in a position of needing a new family doctor. And I spent a lot of time phoning and looking online and looking for new physicians that were accepting, talking to friends, and there was nothing. And then a friend mentioned the Crowfoot practice. And I looked into it, and I decided I would put myself on the wait list. And that was probably 2.5, almost 3 years ago now. So it was very anxiety provoking, because even on the wait list, I remained homeless for a medical home. I was lucky, knock on wood, that I didn't appear in emerge. I didn't have emergent health needs. So I kind of got through that period. And I know that that's not what it's like for a lot of people. And I happen to have some friends right now who are in situations that they also need some new family physicians, as you mentioned earlier. And they are having significant struggles trying to get connected with someone that meets their needs. So I know I'm not alone, and while that's not a really comforting feeling, it is something that I think that we're all faced with right now, and trying to find the right fit. And maybe I was being picky, I'm not sure, but I had some things I needed from a medical home that I wanted to ensure that I was going to get. So it was, it was hard out there. It was hard to wait. And yeah, and I think that my story is not really much different than anybody else's story. So
we've really benefited, Linda, from your input and your awareness of the healthcare system. You're retired as a healthcare provider. We tapped you on the shoulder and asked if you'd help us with Project Rainbow, which Julie Courteau is going to talk about afterwards. But I wonder if you can tell me a little bit about that process of development and the role that you played and what you saw in terms of the discussions that were happening.
Sure. Yeah, I did come from a background in health. It was primarily mental health. But I also had great opportunities to work on some very innovative projects, to look at program development. And when your opportunity was presented to me, it excited me. I think that what you're doing is the way of the future. I think that having a voice of a patient was also something I didn't probably see a lot of in my work. So having this opportunity from my perspective to be the patient voice was, again, really exciting. So I have had nothing but awe, I think, at the team that you guys have put together as this working team. I think it's very exciting to look because I think you're all forward looking. I think there is no one that is stuck right now. We just need to do this. We just need to tweak this. I think anything is a possibility, and I think it's very exciting to be able to be kind of on that ground and to take this trip with the group. And I think any patient would want this opportunity to be able to give some input from their perspective. And I think it's very exciting. And just like the other people, I don't understand why more individuals don't jump on this model, your previous model, 101, and then whatever is coming next, I think is a great opportunity. Having people work to their full scope and having, as a patient, opportunity to build those relationships, I think is a real benefit to me, because my needs are sometimes multiple needs. And I think having a team with multiple skills, I don't have to go shopping elsewhere. I don't have to, be anxious about what they know or what they don't know when I present with a variety of different issues.
No, thanks, Linda. I think, great points. And the diversity in the team and the skill levels, I think I know it results in better care for patients. We had some fun with the focus group too, when we were talking about Project Rainbow and developing the concept, and had some very cool feedback from that group of 12 unattached patients. I don't know, do you have any, sort of reflections from that? I know it goes back a few months.
Yeah, no, I still have some very clear memories. I think there was such a range of people. In particular, I remember the one fellow who was sitting beside me who had very strong opinions about what would work and what wouldn't work. And then at the end of the time of the focus group, I think he was one of the first to say, "Sign me up. This sounds great." Even though he was able to articulate lots of challenges and the what ifs and, what about this situation and how is this going to impact me? He also, I think, recognized that things probably needed to start changing, and that he could probably find a place for himself in that model.
Yeah, and so much rich discussion that night, and so many insights that we gained as a planning group. So Linda, thanks again for your contribution and continuing along the journey with us. We've sort of been teasing about our Project Rainbow and what we're developing and what tool we're going to use to be able to take on these patients. The person that's going to make that happen, no pressure, Dr. Julie Croteau, who is, I'd say, a mid-career family doc who has been with us and Julie, you're going to have to tell me how many years, but who stepped up when we presented this concept to the physician group to say, hey, who wants to lead the charge? So, Julie, I'm going to stop the blah 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 introductions, and why don't you tell us about Project Rainbow?
Awesome! Thanks very much, Dr. Ward, and thanks everyone for tuning in tonight. It's 8 years, Rick,
8 years.
to answer your question. And I'm really excited to share Project Rainbow with you all. As we've kind of already alluded to and chatted about. We've had this team kind of develop Project Rainbow as this new way to deliver high quality, team-based, patient-centered care And really our goals were that it was patient partnered. So we had Linda on board and we were trying to get feedback from patients and bring patients with us to kind of develop a system that would work for them. It's publicly funded, sustainable, and enhancing patient outcomes. We named it Project Rainbow because Crowfoot Village Family Practice, as you likely know, is made up of 5 color teams led by family physicians. And we had Project Rainbow as this vision where there's this diverse multidisciplinary team as the center of care delivery. I just have a diagram I'm going to share with you all to kind of hopefully explain a little bit about what I'm going to talk about. Hopefully this works. Hopefully you guys can see that all. But as we've mentioned, Project Rainbow is different because it has to be, and we have our care needs in our province have shifted, and we know that there's many Albertans without access to family physicians. We really wanted to be able to use our team members to their full scope and still have a family doctor integrally involved and supporting and reviewing all of the care. We really wanted to improve access for patients. So instead of a traditional primary care model, which is kind of on the one side of your screen where you have this family doctor independently managing things, what we've been used to at Crowfoot Village is the centered image where we have the family physician kind of leading the health team. We really wanted to flatten that with Project Rainbow and have this flexible entry point for patients based on their care needs. And we're really hoping that Project Rainbow will help evolve team-based care at Crowfoot Village. And then, like Shauna had mentioned, hopefully we can scale and spread it to the rest of Alberta as well. And we're really hoping that for existing patients, it won't be a loss of a family physician, but really the gaining of this team to really help meet your care needs. As we've been starting with this project, it's been really interesting to meet the patients and try out our team-based care and see and learn. Currently, we have about 250 patients currently rostered to Rainbow Team. We've been identifying lots of chronic illness in patients who haven't had access to care, and we have been able to use our team to meet their healthcare needs. A couple examples that kind of come to mind would be in patients who haven't had screening, we've picked up some type 2 diabetes, and we've been able to connect those people with our diabetes educators and our health management nurses. We had a patient in particular, but a few with some strong family history of breast cancer, and we were able to kind of get them up to date with their screening through our registered nurse screening protocols. At our intakes, we've kind of revamped and developed how we're doing that. And in a couple patients, we identified some financial concerns, and we were able to kind of get them connected with social work without having to have an appointment with me, just through some conversations over the phone with the team. And we're really excited about future development of Rainbow Project as we keep rostering patients. And so that includes some enhanced mental health training, some more kind of preventative and proactive screening. And we're still kind of brainstorming and working with patients to kind of say, hey, how can we make this work and what can we do to make this the best it can be?
Yeah, really exciting stuff, Julie. I mean, if you were to sort of characterize the biggest difference between what Crowfoot is now and what Rainbow Team is, what would be the key difference?
Thanks, Rick. Yeah, I think it's really that flexible entry point for patients based on their care needs. So when patients call in, they get connected with our health navigator, which is at the top of that diagram. And based on your care needs, we kind of ask ourselves, hey, who is the best of our team member to help with your care needs? And is that a physician assistant? Is that a registered nurse? Is that a physician? Is that one of our other care team needs? And then hopefully help patients get faster access to those services if we're really making sure we're using all of our team members to their full scope.
So Julie, it's a bit of a different model of care. And when I look at your diagram, I see that the physician has sort of gone to the bottom of the model, which is a little different, right? Because these patients come in and they're not Dr. Coteau's patient, but they are the patients of the yellow team. What's the feedback and acceptability that patients have reported with that model?
Yeah, so I think two things about that. I would say most of the patients, we've been kind of teaching them about Project Rainbow as we've been integrating them to this. And I think most patients are really excited about the idea of team-based care and are really happy with the thought of, hey, I'm going to meet somebody who can adequately address my needs in a timely fashion. I do think it's a bit of a paradigm shift, though, from this idea of, oh, hey, I need to call my doctor's office and make an appointment to see my doctor and kind of move from there, because a lot of the patients on the wait list are used to fee for service. But I also think it's a bit tricky because currently the health system isn't necessarily set up for team-based care. And so when you go places like to the emergency room or for diagnostic imaging, they ask you not who your health team is or where your health home is, but who your family physician is.
So I started answering on the chat, but Nancy, this is a great question, and I'm going to pose it to you, Julie. Does this mean that we would no longer have a relationship with a singular family doctor, like corporate dentistry? I'm just shivering a little bit, no disrespect to the dentists.
I also shiver about that, but I would say that really our goal is still that the family physicians are involved, leading and supporting the team, and also actively managing patients. I think the thought is that now there would just be other providers as well, providing appropriate care. So not losing the family physician.
Great. Okay, good. And so actually, let me, Julie, I'll get you to take down the visual and maybe just ask Shauna. So Shauna, you're the business person. You're looking at the model of the future. Are we going to turn Crowfoot into Rainbow?
Great question. So I think that remains to be seen. I think right now we're in a learning phase, and I feel like, again, when we're designing the primary care of the future, we are looking to Project Rainbow to see what brilliant things can come that we can give to our team and make accessible to all patients at Crowfoot. And the idea is not that you're going to lose something or lose the connection you have with your family physician, but simply that you'll gain team and you'll gain timely access to care, and you'll gain the ability to get connected with a provider who's really most appropriate for your care needs. So I do see an evolution at Crowfoot. I don't think it's going to be urgent. I think it's going to be sort of slow. I think we'll do it together with patients, but we won't be disrupting the relationship you have with your existing primary care provider. We'll simply be expanding your ability to get great care.
Yeah, and I guess, Anik, great point. Some other good questions coming up that I'll throw to the group. But I mean, let me give you an example of sort of my world. And I think there may be a few of you online right now. This has been my lower back week. I think I saw 5 patients on Monday with lower back pain. And as I said to the last one, you're the 6th person today that's got lower back pain. I was the first one because that's what I woke up with. Well, I'm happy to see patients with lower back pain. The right person to see somebody with a new onset of lower back pain is a physiotherapist. And we're actually in discussions with a couple of the physiotherapy clinics to look at bringing in a physio, so that when you call and say, I need to see Rick because I woke up this morning and I've got this bad back pain, instead of hearing, well, Rick couldn't come in today because he's at home with back pain, what you might hear is, well, we've got a great physiotherapist who's working with Rick, seeing the patients with MSK problems, and let's start off with you seeing that person. So I think I see that as the kind of evolution that we're moving towards. Shauna, am I hitting the nail on the head with that?
Yeah, and I think the brilliant thing about CVFP and having been in existence for so long is we have an electronic medical record that's full of health data of our patients. So we get to look and study that health data and determine what your needs are and how our population's needs are evolving. And then we can customize who we bring into the team based on our patient needs. So maybe it's back pain, maybe it's mental health. So we'll evaluate that, I think, over time. So I wouldn't make a firm commitment to what that's going to look like. I think that will be dictated by our patient base. But it's a great example to illustrate what could be possible.
Julie, back to you. Aggie has asked a great question. What the heck is a navigator, and what's their role? And if Michelle L., I remembered your name, Michelle, is online, we could get her to answer. But Julie, why don't we turn that over to you?
Yeah, I think that is a great question. And so I would say it's probably not too different than what you're used to right now, where you kind of call in and our team kind of gets a little bit of information from you to say, hey, you know, how urgently do you need to be seen? Should we be booking you with your physician? Do we need to be booking you with a different physician? Should instead maybe we have our nurse give you a shout to get a little bit more information? Or do we need to book you an appointment with one of our nurses? We're just kind of taking that and making it a bit bigger to try to help improve access to care for patients.
And so just to be clear, the health navigator is a medical office assistant. So they're not the person who delivers the care, they're the person who coordinates the delivery of care.
Yeah.
Yeah, great clarification. In many ways, she's sort of the person that helps to align needs with resources, and really it's a huge skill. And again, we've got great people, Bree as well, who are in this role now, and it's evolving. JR, Dr. Reynolds is again one of the visionaries around team-based care in the province. You know, your comments about Project Rainbow and how you see it fitting into the future.
I think this is almost like the extreme leading edge of full scope team-based care. So I think what we're learning, and the secret sauce right now for me is our registered nurses and that role that is underutilized, I think, in general in primary care. But it really is, Rick, a perfect example of how we can have everyone working to their full scope and yet not have a patient with multiple concerns, because you said you're not seeing anyone who has just one single concern. So we're not trying to fracture your care. You don't have to come in today for your back pain and tomorrow for your diabetes and the next day for something else. We're really going to be testing what this looks like in the most effective, efficient way. So if you really have all of those issues, perhaps an appointment with the physician who can navigate all of those things is what you need, as opposed to you know, a registered nurse who can talk about your screening and has some extra mental health training and address your, you know, early symptoms of maybe mood disorder or adjustment from a grief reaction or something like that. So I just think it's us continuing to lead that and then write the story about it, Rick, so that we can replicate it elsewhere.
Yeah, has there been interest from other clinics, or is this you know, the best kept secret in Alberta, or do other people know about this?
Well, Rick, at the provincial PCN forum last fall, we gave a big presentation, and I think there's great interest. We had so many questions and lots of eyes watching and waiting and wanting to learn with us, and hopefully get started soon, because we aren't the only people who recognize that we won't have enough family physicians to attach or meet the needs of 800,000 Albertans that don't have a family physician.
Great. Some great questions coming in. So I'm just going to go through and pick off people. Ian, you had a really important question here, and I got a text from Dr. Ian on our side saying, "Oh my goodness, make sure you answer Ian's question." And Ian said, who's going to be responsible for the external coordination with referrals to cancer centers? How do you maintain that informational continuity? If you've got a team, how do we ensure the right hand knows what the left hand is doing? And also, how does it intersect with the medical ecosystem at large? Julie, because you're really in the weeds with this one, and I know this is something the team has talked about, maybe I'll throw it over to you to address that.
Yeah, so I think there's a few different pieces of that to address, but I would say that as part of Rainbow Team, we're really working on communication within our team. We have regular meetings to review things and discuss things. And so we're really trying to make sure that, again, there's this closed loop communication and everyone's aware of things. I think we're also using technology to try to help us on Rainbow Project and ensure that chart information and health information and all of those things is accurate and up to date. And then we're also hoping with this registered nurse role to develop that into a care lead role so that patients would have a point of contact or a link if they had any questions or concerns more than the health navigator could manage. At Crowfoot, we're also lucky that we do have a referrals team that we currently use as part of our current patients as well as with Rainbow to follow referrals and track things and make sure that nothing's falling through the cracks.
Yeah, and I'm going to add on to that, Ian. I usually put my foot in my mouth at least 2 or 3 times a day, and my last one today was one of the patients who was waiting on a referral to see a urologist, and he said, when will I hear and how do I know this is being worked on? And I said, our referrals team are like dogs with a bone. They just go after and make sure these referrals get through and the communications. And I got deathly stares from my team saying, dogs with a bone. Could you come up with a better analogy, Rick? So, but I think the point is that when we started the Project Rainbow journey, one of our mantras was we must maintain the excellent care that we provide, and our team Rainbow team patients will get every bit of that great care. So great point, Ian, and something that we've looked at. I just want to, I know Dr. Johnson, Ian Johnson, who's active on the chat, has answered this, but I just want to go back to a comment, I think by Manish, and sorry, I'm just missing your name. Oh, there it is. So the question was, so when does this Crowfoot Village 2.0 start? And I'm gonna get Sean to clarify, but what I heard is 2 things. Our current business model is not the model of the future. There are challenges within our current funding model that will need to be addressed and dealt with Alberta Health as partners in that. And that's a work in progress and something that we're ongoing talking to Alberta Health about. But the evolution of Crowfoot to a yellow Crowfoot, a rainbow Crowfoot, to use that analogy, is that a sure thing, Shauna, or is the Crowfoot 2.0 more around the funding model that we're moving towards?
Well, I think we're talking about 2 things that are wrapped up into one thing. So the foundation of the care that we deliver is our funding model, but what we do is provide excellent clinical care. And as I said before, what we were doing between 1999 and 2020 won't work anymore. So we have no choice but to evolve and innovate. So we're there now. So we're learning as we speak, we're in it. So 2.0 has begun in that we're designing it as we speak. So that's what Project Rainbow is really this grassroots effort that we're looking at that informs how we can continue to evolve team-based care. And then we'll take our learnings and infuse those into the existing teams as it makes sense. That's not to say that the existing teams will function exactly like Project Rainbow, but I wouldn't say that we know that for sure yet. And certainly we now know that patients need to be partners in their care. So we will consult you along the way so that we design a service that meets your needs. But make no mistake, again, to reiterate, we will never hire enough family doctors to fill the gaps in this province. And so team-based care is absolutely the way of the future. So one of the calls to action that I would have for you tonight as patients and the public is to reflect on your expectations of the primary care services you receive and to start to think about what team-based care would mean for you and what kinds of feedback you would have for us to make sure that we design it in a way that is aligned with your care needs so that we don't design it too far away from that. At the same time, we are also working with Alberta Health and the Ministry of Health to inform them of our experiences and our outcomes and the kinds of reform that are needed to our funding model to ensure that Crowfoot can exist long into the future and that we can bring our colleagues in the province with us.
Yeah, I think it was you, Shauna, that said in a really cool way of we're not riding the wave of reform, we are the wave of reform. And, you know, we've certainly offered our expertise and are continually sharing our experiences with Alberta Health and with Government of Alberta because we think that we're onto some pretty cool stuff in terms of dealing with the primary care crisis. Hey, I have to address this. Dirty 4MP. This retirement word is only one that I get asked about like 80 times a day. So the question is Project Rainbow sort of a way of allowing these old dogs to go out to pasture? The answer is no, that Project Rainbow, really the raison d'etre of this is to attach more patients to a medical home. Project Rainbow is Crowfoot Village Family Practice's answer to the community problem of there is not enough primary care opportunities for patients. So we're actively working on that unattached patient registry that we have and attaching them through Project Rainbow. And as Wendy said, Wendy, remind me of what that number is, that, and we know it's a stretch goal, but remind me of that number that the board said they wanted to get to with Project Rainbow.
3,500.
Sorry, once more.
Oh, I'm having internet issues. 3,500, 15% of our current panel approximately.
All right, and so we're closing on the 10% part of the goal then. Just wanted to address, so, and JR, maybe I'll throw this question to you. There was a comment about, are you going to recruit a doctor who's an expert on patient with seniors issues?
Yeah, I think what we want is generalists. We want people working to their full scope, and we don't want little specialty clinics within the clinic. As family physicians, we do have a lot of expertise in seniors care. Cradle to grave or birth to death is the care that gets provided by a family physician and the team. So to Shauna's point earlier, though, Rick, we're going to look at the needs of our population, and if there's expertise that we don't have, we'll make sure that we get it. And it might not be one individual, it might be we all need some upskilling.
Yeah, great answer. Is Jan still online? I'm going to love to throw this question to him. And will alternative medicine be concerned or considered as well. Should that rainbow team include non-traditional practitioners? Jan, if you're on the line and can throw some thoughts in around that, love to hear them. If not, I'll maybe turn it back to JR. Oh, she's jumping at wanting to answer this. Janet. Go ahead, Dr. Mills.
Okay, Jan's not here. I think the focus of the care we deliver is what would be funded by public health care, so your taxpayer dollars. And so it's not that complementary or alternative care is something that we don't, that you can't access and be part of be a patient at Crowfoot Village Family Practice. It's just our focus is on what's covered by your Alberta healthcare number. Yeah, I'm sorry, you're back, so go for it if you have something to add.
I think what we're looking at is, in addition to having doctors serve patients, kind of what everybody has been saying is to fully utilize as much of the health team as possible in terms of allied healthcare providers. So when Rick was talking about bringing in a physiotherapist, I think that would be tremendous. It would be a tremendous asset to our patients to be able to offer that service, the most appropriate service for a patient's healthcare needs at that time.
Yeah, and Jan, to your point, we've got a pretty diverse team right now. I mean, we've got obviously our family physicians, we've got our outstanding nurse practitioner, we have just brought on a physician assistant. Our family practice nurses have been working incredibly with full scope of practice. We have an arrangement to have respiratory therapists in for our patients with asthma, COPD. We have a behavioral health consultant, Mary, who in conjunction with Calgary Foothills PCN, shout out to them, looks after our patients that require mental health support. We have our incredible pharmacists who are embedded, Esmond and Amy, Jen coming back from maternity leave, fingers crossed, who do the heavy lifting when it comes to our patients with diabetes, hypertension. We've got our health management nurses who focus on prevention. And am I forgetting anybody, Shauna? No, I think I've got them. So we've got a full spectrum of providers in-house in one location, as well as access to the incredible extended team through our Calgary Foothills PCN, which actually, fun fact, is sitting over in our old office at Crowfoot, not the Silver Springs next to the vet office, but the intermediate space. Oh, and hey, that reminds me, a fun fact that came up, I forget who it was that asked, but asking if we would be using the same protocols that 811 uses, HealthLink uses, for triaging patients. The answer is no. The fun fact is that HealthLink 811 started in Crowfoot Village Family Practice when we evolved to our team-based model. And the cool thing that happened then is as those HealthLink nurses were going down the algorithms with our patients, they would at times walk out of their office and say, Rick, I've got Mrs. Schmoo on the line and she's got this, this, and this. The algorithm says I should send her to Emerge. Is that what I should do? And we would be able to have that dynamic communication and say, well, no, I know Mrs. Schmoo and we do not want to send her to Emerge. We want to bring her in here and do A, B, or C. And that's the kind of thing that's happening right now with our health navigators and in fact with those telephone folk that you interact with when you call in, is they're going to make their best judgment, but they're also going to look over at the nurse and say, hey, Mrs. Schmoo has got this, should we be bringing her in? Or grabbing me or one of our docs and saying, hey, can I run this patient by you? So we already have that incredible interprofessional communication that provides, I think, really optimal care. So there's the there's the rift to that. Morley says, will the team have the authority to do prescriptions, approvals, referrals, diagnosis? Maybe, Janet, can you maybe speak a little bit to the scope of practice of our non-physician providers and how that's represented in the Rainbow team?
Yeah, so the physician assistant who also sometimes supports Julie in the care, under the supervision of a physician, can do all of those things: referral to another specialist or specialty clinic, order lab work and diagnostic imaging, and prescribe anything except an opiate. We can delegate. So Julie alluded to, screening measures. So ordering colon cancer screening fit tests or mammograms, that can be delegated to another healthcare provider, like a registered nurse, who can very well give you a requisition. And the coordination of your care, may be the role of Julie on Project Rainbow, or the physicians in the future are more the health managers. And so the people that, our health system is still designed to need the name of a physician. And so there are still rules that are out of our control around referrals to specialists and so on. So you need a physician's name, but again, that delegation is probably the biggest part.
Yeah, I think we're, again, fortunate to have multiple providers, Morley, especially for that. I need a prescription for. We've got multiple providers, non-physicians, who are able to help with that. Mahesh asked another really good question, and I'm going to paraphrase it. And if I've got it wrong, Mahesh, then just type in the chat. So if there are patients that are currently rostered to one of our physicians in the traditional model, and they said, this Team Rainbow looks really cool, I would like to switch over and become a Rainbow patient. Julie, what are you saying about that? Is the Rainbow team open for cross referrals, or is your focus going to be on unattached patients?
Yeah, so currently our focus is on unattached waitlist. And as we had mentioned a little bit earlier in the session, we do have quite a number of people on our waitlist, and they've been on there for quite a bit of time. And so we're hoping to work through that group of people as we're kind of developing and growing, and then kind of see what happens after that.
Yeah, and again, Pam Whitnack is typed a comment, and Pam is again a leader in healthcare in Alberta, who's enjoying semi-retirement, I think, Pam. And she asked, have you considered adding health coaches to assist with lifestyle changes? Boy, great question and great concept. And first of all, yeah, let me, JR, again, I'm going to throw this one to you. Dr. Reynolds, do you see that as being a part of the team? Cool idea. What do you think?
I absolutely see that as part of the future. Ian put it in the chat, but our health management nurses do take a coaching approach to lifestyle management, lifestyle changes with patients. The coaching approach is something that's really becoming embedded in healthcare and how we teach even our learners. We're not teachers or preceptors or mentors anymore. We're coaches when we teach a doctor in training. And I think I would like to empower patients as well, and maybe look at some peer mentoring, and maybe that's the wave of the future as well. So there are so many opportunities, Rick. And I think, doing something, thanks to you for being visionary and coordinating us to do this tonight, but connecting with our patients at this level is the antidote to my burnout. So this is, really makes sure that we keep our joy at work. I think we have a really happy group, but connecting like this is really helpful. Thanks.
Yeah, thanks. And I love your comments that, and Linda, I think you experienced this too when we did our focus group. You know, the energy and the power and the input that we get from patients when we have these kinds of dialogue, it just really recharges our batteries, and it feels like work that's worthwhile and that's making a difference. And boy, it helps us get up in the morning. I want to turn back to bringing in the voice of the patient. And I also want to do a shout out to Patrizia, who is camera shy. She should be on this panel, but she has worked with us for the last 2 years in helping the physicians and our team understand the patient's voice, and importantly, how to bring the patient's voice into the discussion. And you know, there's been some comments about how do I, if I want to add my voice to the voices of other patients who are providing input, how do I do that? So Meredith is going to put on, if you want to be involved in the future, patients@cvfp.com. She's going to put that in the chat. But I wonder, Sean, if you could speak to the PEP squad. I always have to remind myself it's not the PrEP squad, it's the PEP squad. Tell us about that. And again, Patrizia, I hope that you're taking a bow for this in the background. Shauna, tell us about the PEP squad.
Yeah, well, to introduce Patrizia, she is our communications specialist at CVFP, and that was that role was an idea born of Dr. Ward, who thought, you know what, it's really time. We really need the patient voice more prominently, and we need some expertise around how to do that. So Patrizia has been such a welcome addition to our team and has really captured a way to bring in the patient's voice and to give CVFP a voice too with patients. So thanks to Patrizia. So one of the things that she co-designed with us is something we call our PEP squad, which is the Patient Experience Partner Squad. So this is really a group of patient volunteers who contribute their time and energy and experience to helping us in a variety of initiatives. So I think currently we have just under 300 patients who have volunteered. So when we come up against something where we feel like, gosh, the patient voice is going to be really important for us moving forward, then we engage with the PEP squad. So that's in a number of ways. So the first might be just a simple survey. So we'll send you a survey to capture information on what your experience is and how you're navigating the health system. And it can be all the way up to inviting you to participate in a focus group or on a working group to help us design something different at CVFP. Sometimes it's service delivery, sometimes it's processes. So a couple examples of work that we've done with our patient experience partners to date. We looked at how we were orienting new patients to Crowfoot, and we found that new patients were often overwhelmed and that the information they were receiving was lots of paper and lots of forms to fill out and lots of pamphlets and brochures. And so we had feedback that it would be helpful to streamline that. And so we had our patient experience partners come together and help us build new tools to orient patients to CVFP, teach them what we are, how we work, and what it means to be a patient of the clinic. And now we have a very simple, I think it's about a 6-page guide that was completely designed by patient. It's electronic. We have supplemental videos, and not only for new patients, but we've actually sent it to existing patients. Currently, we're also working right now, as we speak, on a patient feedback process. So when you have experiences in the health system and specifically in Crowfoot, good or constructive, we want to know about that. And some patients don't really know where to go to provide that feedback. And some patients don't necessarily feel comfortable providing that feedback directly to their family physician or team. So we're working with patients to design a process that feels safe, transparent, and easily accessible and results in follow-up and transformation where needed. So we're just in the early stages now, but typically what we do is a call out to those folks, and you get to choose what you participate in and what not. So that's totally up to you, but we'd love to grow our PEP squad. So I think that's where Rick is going with this.
Yeah, absolutely. And again, Meredith is going to put that link in the chat. If you have interest in that, then we'd love to hear from you. Patients@cvfp.com. Yeah. So Sandra asked a good question, and I truly was not ignoring it, but just trying to get the courage to answer it. Is the government and AHS listening to these fantastic ideas? Healthcare is being politicized. Perhaps all of this will be subsumed by what has been dedicated for political reasons. You know, Sandra, I've had the privilege of sitting at tables with a lot of the healthcare leaders in the province. And I know that our executive team here has worked with Alberta Health and with government of Alberta. The Minister LaGrange has visited the clinic. We've had lots of communications with Alberta Health so that they know that we are willing partners. I can also tell you that they're working very hard at trying to deal with the primary care crisis. Our message to them consistently has been that we think that we have some solutions to offer going forward. We continue to be dialoguing with them and our colleagues across the province. You know, there was, I think, a comment earlier about it takes a village. You know, it's going to take many ideas and lots of innovation to solve the problems that we have in healthcare. And I think it's just cool that we've got so many dedicated leaders. And, you know, I'm talking of my colleagues who've been on this, who really are aligned in trying to make that happen. Guys, we've got 6 minutes left. We've got some really good questions. I think most of whom we've got on here. We'll try and get back on the chat. We'll try to get back to people and feedback some of those answers. But I just wanted to take the last minute to go around the table and just, I know I'm surprising you guys. I warned you I would. If there's one key message that you want to leave our patients with tonight, Jan, why don't I start with you? What's the one key message you'd like to put out there tonight?
Well, I think there will be changes, but I don't think our patients have to worry about the quality or the continuity of care that we'll be able to offer, regardless of what happens in the province in terms of health politics. We will continue to be able to provide all of our services, and some of our services will be much more enhanced for all of our patients. So I just want to reassure patients for that.
Great comment. Wendy, chair of the board, and also I forgot to mention the chair of Calgary Foothills Primary Care Board, Physician Court Board. Wendy, what key message would you like to leave our audience with tonight?
You know what? I will end with the fact that I'm immensely proud of this group. And as we've been talking about team-based care for our patients, we work as a team. Everybody's bringing an amazing set of skills to this, and we will get this done. It may not look exactly like it does right now when all is said and done, but it will happen, and we are really happy to be leading this in the province. Thanks for everybody who's attended. Thanks for your time.
Yeah, thanks, Wendy. Right on. JR, your end of the webcast wisdom.
I think I'm going to stick with my comment around the antidote to our burnout is really being partners with our patients and doing this together. We don't want to do anything to you or for you. We want to do it with you. And so please sign up for the PEP Squad. It actually brings us joy, makes our work easier, and hopefully will improve our health outcomes.
Right on. Shauna.
Yeah, so I think I would echo what folks are saying already and something I've said already. Primary care has got to change. That's a known and a given, but I think it's going to change for the better. So to reinforce what Jan was saying as well, you're not going to lose anything, you're going to gain, and we need to do that with you. So again, 2 calls to action. The first is, please consider joining our PEP Squad so that we can really weave your voice meaningfully into what we're doing at CVFP, but also reflect on and engage with your networks and community about where you think primary care should go and how you see it evolving, recognizing that team-based care is absolutely the way of the future. So the more you can reflect on that and think about that, the more you can help us design it with you.
Great words. Dr. Julie Courteau, the pot of gold at the bottom of Team Rainbow. I had to get that in there, Julie. your last thoughts.
Yeah, thanks, Rick. I would echo all these other very wise voices and just say, you know, we know healthcare needs are changing and we know things need to change. And at Crowfoot, we're really excited to innovate and create solutions and really work on improving healthcare and bringing you as patients along with us on this journey. So just really thankful for everyone tuning in tonight and listening and being part of the PEP squad and everyone's kind of excitement and energy around this.
Linda, it may be appropriate for the last word to go to you, our patient advisor.
Just quickly, I would say change can be really scary, but change is also very exciting. So I think that's the ride.
Yeah, I love that, and I've been following the chat. Peggy Offrick, who we're blessed to have with us tonight, she would have a lot to say about change and change fatigue and maintaining the motion. But the change can be scary, but I think we've seen it really pay off. So thanks for those words. Just a couple of quick comments on comments. I think it was Gord Ross who asked about AHS being split up and the implications of that. I won't speak to that directly, but what I will say is that one of the things that we've, again, an epiphany I think that we had at our last board retreat was to say we have to work within our scope of influence. There's stuff that we can do at Crowfoot that nobody else can do, and that as long as we stay in that space and not worry about what's happening in the bigger ecosystem, then we're going to have lots of fun in doing that. Sorry that if there was comments that I didn't get to. Thanks for all the cool notes in the chat. So I have 3 key messages. Yeah, I had time to think about this, so I was able to write things down. So key message number 1, although there's lots of challenges in the world of primary care, right now at Crowfoot Village Family Practice, we're doing pretty darn good. In terms of the business side of Crowfoot Village, we are working in a funding model that was right for primary care 25 years ago. It's not going to be sustainable going forward for lots of reasons. So we need to work with our funder to develop what that looks like so that we continue to provide evidence-based care that's right for patients and that is financially responsible. And I think the last thing is that Project Rainbow is our attempt to innovate, to try to address the needs of unattached patients. We've got some incredible, powerful, intelligent voices backed by some great feedback and input and partnership with our patients. I think we're all going to make a difference in healthcare. So thanks everyone for attending tonight, and thanks for your comments both now and in the future. Hey, why don't we do this town hall again in another year, and we'll give you an update on where the rainbow is shining. Thanks again, everyone. Oh, and Trevor and Meredith, the wizards behind the screen, for setting all this up. Couldn't have done it without you guys. Thanks again, everyone.